go!
Okay, without any further ado, this guy has been on my podcast a bunch of times. He was one of the stars of the movie Fat, a documentary. He's also the guy that heads up the Lifestyle Medicine Clinic at Duke University. Love everything about this guy. Please, folks, put it together. Big Rudy clap for Dr. Eric Westman. Eric, you take over.
Thank you, Vinny. It's a pleasure to be with you today. And I just have to say I thought I had a cameo role, not really a starring role in your documentary, but your work has been so helpful for so many of my patients here in North Carolina and helpful to just about everyone. So thank you. It was great to be involved in that documentary that you did. Today, I'd like to, as usual, blend in some science, some clinical reality of what I see. I'm in practice at Duke University, and we changed the name of our clinic about 18 months ago from the Lifestyle Medicine Clinic to the Keto Medicine Clinic, because I had so many people coming through saying, really what you do predominantly is the keto diet, because you're not talking about exercising so much and all these other things. So I do have that news and a couple other things to point out for the first time today. Some exciting news that we have. And let me pull up my PowerPoint here. And let's see the entire screen.
There you go.
Okay. Is that working okay? So the title of my talk is Using Low Carbohydrate Diets, but as you'll see, it's predominantly a keto diet to treat type 2 diabetes. And I listened into Ivor's talk. I agree with everything that he said, really. It's great to have him lead in, so then I don't have to mention the word cholesterol throughout my talk. A few disclosures. I am an associate professor of medicine at Duke. Been director of the Lifestyle Medicine, now Keto Medicine Clinic, since 2006. And that was after we published papers on the low carb keto diet. And these are like ancient history now, but we didn't just dive into doing a clinical practice. We did the research to show and validate what we did. I am past chairman of the board of the Obesity Medicine Association, which is the largest group of medical weight loss doctors in the world, and I teach keto diets there. There are a growing number of doctors, and you're having the pleasure of seeing several doctors in this summit who are using keto diets or very low carb diets in their practice. I am co-founder of Adapt Your Life, which has keto products and education. I am announcing really today the new Adapt Your Life Academy. So we've worked really hard to simplify the message, and you'll see my approach in the talk here. But if it intrigues you, stay tuned. We have Adapt Your Life teaching courses in development and rolling out very soon. I am co-author on a few books. Dr. Atkins was one of the pioneering low-carb keto doctors, along with Dr. Eads, Dr. Bernstein, Dr. Rosedale, and I was able to be a co-author on the New Atkins for a New You with Steve Phinney and Jeff Volek, and that was published in 2010. Dr. Atkins died in 2003, and we actually learned a lot from Dr. Atkins and have refined a lot of his teaching into what we do. There is a new book coming out. This is the other major announcement today, a book called End Your Carb Confusion. I teamed up with Amy Berger, who is a writer. You may know her from Alzheimer's Antidote, and also her blog and YouTube channel, Tuit Nutrition, tuitnutrition.com. It's available now at Amazon for pre-sale, and it's targeted to come out by Victory Belt in December 2020. So check out the End Your Carb Confusion. Switching gears, today in my clinic, and maybe you personally think there's a bunch of information on the internet. You're drowning, don't know where to begin. The keto diet, what does it mean? Do I have to have keto shakes and keto cookies and keto, well, I would like to simplify and try to explain where the confusion is coming from. So from my view, I'm not talking about on the left-hand side, upper left-hand side of the fire hose here, spigot coming out. The ketogenic diet for epilepsy has been around about 100 years. Overnight, it can fix some children. It's miraculous. They have to be very careful with the carb level, keep it very low. They have to have protein and fat ratios at every meal, and they monitor the macros, and a little bit of sugar can bring on a seizure. That's not what I'm talking about. Although that's part of the confusion. You'll see a lot of people focusing on the macros, using apps and strictly at every meal, worrying about this, that, and the other thing. That's not the research that we did. That's not the LCHF, LCKD at the bottom here. And then you may hear about paleo and primal, which brings in the food quality, eat like a caveman, and this brings in the grass-fed beef and keeping the oils perfectly right. But the paleo primal doesn't involve the keto metabolism. Often the carbs are relatively high and you won't get the same keto effect. And yet that's in the keto diet message that you see, especially someone who doesn't have a clinic where they can just expound the guru information. And if it doesn't work for you, well, there's no recourse to go back and say, hey, this isn't working. Well, that's my life, is people come back to me and say it's working or it's not working. I'm in a clinic every week, 4 days a week. In the middle of the fire hose of information here, what I'm talking about is LCHF, or that's low carb, high fat, a term coined by the Swedish group dietdoctor.com. LCKD is what we call it in our research papers. It's also known as carbohydrate restriction, low carb ketogenic diet for LCKD. And we use total carbs, not net carbs. To my knowledge, net carbs has only been studied in a couple papers, and it doesn't work as well as total carbs. So that's why I use it in a medical clinic, as I show you, and I'll show you my technique that we use with clinical practice today. Now, it's been interesting to see what I use being called lazy keto, not because you're lazy and you're not worth anything. It's lazy because I don't make people count things. I don't make people be too concerned about where they get their food. And that's why it's called dirty keto as well. And I often thought, well, actually, these are good terms because it means you don't have to be worried and counting macros and measuring ketone levels in the blood and breath and urine. And what if I'm not in ketosis anyway? No. What I'm talking about is a method that's been working for over 150 years. It wasn't Dr. Atkins who first started this. It was a man named Mr. Banting in London, England, actually in the 1860s. So this has just been refined through the years. And as you heard in the lecture before, this has gone through the ringer in terms of cholesterol and focus on LDL and all that. And now I hope you rest assured that was just a big distraction. So this has been around a long time. The research yet still doesn't give me a clear idea of how to use total or intermittent fasting. I'm waiting for research papers, not just anecdotes and books. And then exogenous ketones, the idea of drinking or eating or ketones. No, I want your ketones to come from your body fat if you're losing weight and if you're fixing diabetes. So those are outside the circle here, the fire hose, because I don't see the science yet evolve to a level where I can use it confidently in my clinical practice. But I have to acknowledge we were all taught that a low carb or Atkins or the fact of eating fat was bad. We were taught that, and this is a classic cartoon. I've just changed the name of the diet. You went on keto and lost 90 pounds, lowered your cholesterol, cured your high blood pressure, and now you're walking 5 miles a day. But I'm warning you, a keto diet is bad for your health. And I see well-intentioned doctors, even one recently, say, oh, you should do with healthy keto, where you want to avoid saturated fats and all that. And I had to politely educate other doctors about this. And that's my role. I'm a scientist. The science came to a certain point. I'm a teacher now, teaching what the science has taught us. So for obesity, which I'm not going to talk about today, the most information is known about low-carb diets for obesity. And this is a infographic from the public health collaboration in the UK led by Sam Feltham. And he's got it down into a website and an infographic or all the tables of low-carb, low-fat diets. And this is where I send people, if they still aren't aware that there's so much science that there is for the use of low carb and obesity. In fact, the score is 31-0 if you look at the studies that have statistically significant differences in terms of obesity between low carb and low fat diets. It's not even close. The body of evidence would surpass the FDA phase 3 requirement for a drug if there was one for a diet, but there is no FDA process of regulating diets. I kind of wish there was, and then that would weed out all of the stuff you hear, make it simpler. But if it were a drug, it would be FDA approved. And if the results you see in that I show you in this lecture were in a pill, this would be a massively important and popular pill. But it happens just by changing the food. And that is one of the issues, conundrum, because most doctors don't understand nutrition. They didn't get it teaching in medical school. They still don't today. And we're really looking for drugs and pills and things. But you can do this on your own and get the results without all of the medications that the doctors have in their minds and in their training. There is a major, that organization I am past president of, the Obesity Medicine Association, has the low-carb diets in their algorithm guideline. This is just the slide that has the tools of an obesity medicine specialist: lifestyle, medication and lifestyle, very low-calorie diets. And within the guideline, the dietary approach includes a very low-carbohydrate diet. So if you achieve a lower calorie intake, whether it's restricted fat or restricted carbohydrate, it will help people, and it's clinically relevant because it's a potent way to help people lose weight and fix diabetes. So obesity, all this evidence, it's being used over and over. Guidelines incorporate it now. For diabetes, the published science is not quite as solid. Although you read about diabetes, people have known about this for a long time, that you reduce carbohydrates. And when you look at physiology, it makes sense. So when you increase your carbohydrates in the food, the blood glucose spikes or goes up. That's, in red, the blood glucose goes up. The pancreas secretes insulin to lower the blood glucose because the body doesn't like the blood glucose to be high. I mean, I guess it's risky to have a blood glucose being high all the time. That's called diabetes. So insulin lowers the blood glucose, puts glucose into the cells. What most people don't know is that insulin signals the body to make glucose into fat. So actually, we store fat, not glucose. Well, maybe a day's supply of glucose and glycogen, but we store fat. So then the blood glucose goes down, you have low energy, mood swings, you have carb cravings again, and the cycle repeats itself. So actually, the common theme is you don't want to eat things that raise the blood glucose much. And because that will stimulate the insulin response, which has all these downstream effects and leads to obesity, diabetes, metabolic syndrome, and all these other problems. So if you want to see it in paper form, there are numerous papers, but really this is just common sense physiology that most doctors haven't received. So we teach this all the time, but in this small paper, you can see if someone didn't eat carbohydrates, on the panel on the upper left, the glucose didn't go up. And then because the glucose didn't go up on the bottom right panel, the insulin didn't go up much. And I see this a lot. Well, protein raises the insulin. No, not much. It's a very small amount of insulin elevation after protein. Glucose rises in the blood as a result of the sugars and the starches, the carbohydrates that are eaten or drunk. Okay, well, let's talk about glycemic index and carbohydrate grams. And well, if these are the foods that raise the blood sugar, how do we look at these foods? Well, on the left, you can see the chips and the biscuits, cakes, ice cream will raise the blood glucose the most. This is the glycemic, means blood sugar. So you want low glycemic foods, basmati rice, vegetables, lentils, pasta. But on the approach I use, we're more precise because we don't look at glycemic index or glycemic load. We look at the carbohydrate grams. And actually the grams of carbs in the food that I want my patients to eat is so low, it really doesn't fall on the glycemic index list. So that's where this is like a super low glycemic index diet. So it uses the same principles of a glycemic index, low glycemic index diet. It just takes it even lower to make sure you don't raise the blood glucose, if at all possible, from the food you eat. So on the right-hand side, so we're talking now carb grams, and this is total grams, not net. Net carb subtracts out the fiber, subtracts out sugar, alcohol, under the false impression that these don't impact the blood glucose or keto metabolism, and they can. So again, I'm trying to be more scientific, more precise. We use total carb grams, and you can see the vegetables that we're going to talk about. Zucchini, 1 cup, has about 3 to 5 grams. You can't. That's the other interesting thing about these apps. People come in saying, "Oh, I'm eating 14.2 grams of carbs a day." No, you can't be that precise. There's a false feeling of security that these apps will tell you exactly, and they just can't. But so we focus on food that mainly doesn't have carbohydrate in it: the fish, chicken, beef, shrimp, oil, butter, margarine. And the principle with obesity, but especially for diabetes, is you don't want to eat something that raises the blood glucose. And here's why the glycemic index just isn't low enough, because the system we're talking about, the amount of sugar in the human body. So let's say you took my blood, poured it out, and then crystallize and find out how much sugar is in my entire bloodstream. I will ask this of university professors of endocrinology, and they won't know the answer. Because why is this relevant? Well, it's really relevant because if you eat more sugar than is in your bloodstream, your sugar goes up, your blood sugar, your glucose goes up. So you do the math either in millimole per liter or milligram per deciliter. You assume you have about 5 liters of blood. Well, I met someone who only had 3 liters of blood in her body, so she could only eat even less glucose. So I guess we were talking about apples. She could only eat a quarter of an apple in order to not raise her blood glucose, assuming the apple was absorbed pretty quickly. So it turns out when you multiply all these out with algebra that my teenagers were taught in school, and there's 5 grams of sugar in the entire bloodstream, and that's glucose specifically, at any given moment. So I use this as a teaching tool for people who come in and say, well, why would I ever want to eat something more than 5 grams of sugar? Exactly. Because that's the amount of sugar that's in your entire bloodstream. You eat more than this, it will raise the blood sugars. And this is really, I'm just talking about this phenomenon of the blood sugar going up, the different foods. And what's not taught in the low glycemic and even low carb diet for obesity is that the amount of sugar, if you're treating diabetes, has to be very, very low. And the lower you go from 100 grams to 50 grams, you will have an impact on the blood sugar. It will improve if you have diabetes. The lower you go, the better the improvement in the blood sugar. Now, as I mentioned, for diabetes, we've known this. It makes sense, right? Something has sugar, it raises the blood sugar. So 100 years ago, I was quite surprised, 22 years ago, when one of my patients brought this book to me, that the low carb diet was used for the treatment of diabetes in the early 1900s. In fact, I went to Montreal and handled the first edition of this textbook of William Osler. And in the 1880s, still it was a low carb diet, high fat, even a little bit of alcohol. A lot of my patients find that very quickly. And so it's not rocket science to think that if you ate and drank less sugar and starch, that your blood sugar would be improved. But, I'm afraid I meet these professors of endocrinology who spend all their life looking for the cause of the diabetes inside the cell without regard to what is the organism is eating or drinking. Or what they'll say is that, well, I can't change what people eat and drink. And yes, that's what we do in a lifestyle keto clinic. So the science, again, we went through an era where high-fat diets were demonized, and there was a taboo to study high-fat diets. Thankfully, that's been lifted. If you look at this meta-analysis, which is a study of studies, the node or the circle is the number of studies, and the number of people in the studies, and then the thickness of the line is the number of studies, so that there is as much research on a low-carb diet as there is on a Mediterranean diet for the treatment of diabetes, these small little nodes. And while the low-fat diet has been studied the most, it really doesn't have much effect for diabetes. And there are research papers coming out, and this is the summary of that meta-analysis, that there were 56 trials enrolling 4,900 participants with 9 diets. And for reducing hemoglobin A1C, at the bottom here in quotations, the low-carb diet was ranked as the best dietary approach, followed by the Mediterranean and the Paleolithic diet compared to the control diet. Another important point is that a lot of healthy diets will work. I'm not just saying this is the only one that works, but it is a very powerful one. So a pioneering study, you'll hear about this and get various perspectives on it from many experts. It's really important. If you are looking for the latest science, you have to read this paper. The results are now in several journals, I think 5 papers so far. The title of the paper is Effectiveness and Safety of a Novel Care Model for the Management of Type 2 Diabetes. They put 262 people with type 2 diabetes and obesity, mainly, pretty much all Caucasian, because it was done in Indiana. Sarah Hallberg is the PI on the first paper that came out. The ketogenic diet was taught through classes or a web-based program, and with an app. The goal was nutritional ketosis for 2 years. And this is really the best insight, best look in the research paper as to what happens when you know people are in ketosis. People are measuring their blood ketones. It gets Bluetoothed back to the study people. In my papers, in my studies, I recommended a keto diet, and many people measured urine ketones, but I wasn't exactly sure, as well as in this methodology with the blood ketones. So blood ketones, body weight was used. There's an app. You can even talk to the diabetologist who would help you reduce the medications through the internet app. The hemoglobin A1C reduced from 7.6 to 6.3 at 1 year, and from 7.6 to 6.7% at 2 years. So there was a sustained hemoglobin A1C reduction, but that's not all. There was also body weight change, because this type of approach also helps you lose weight. And it was sustained to 10% at 2 years, this is comparable. This is drug-like effect, actually. And then that no other drug can do this, reversing diabetes, because a drug just manages diabetes. Diabetes was reversed in 54% and put into remission in 18% of participants. Now, I know in our study, low glycemic versus low carb diet was published back in 2008. Smaller number of people. And so when I started publishing and researching this, I felt comfortable using this in a clinical setting. And I'll show you results that I've had in people since that time. A lot of people wanted to wait for a clinical study that was published. And now this is the one that we look at for the best information on what happens when you cut carbs in a well-formulated keto diet in regard to diabetes. The metabolic effects are documented, and this figure is fantastic. It's brilliant, because it's pretty much everything you want to know about the metabolic risk. And everything is better. It goes in the direction that you want, except one thing. And if Ivor was on, I think he'd probably be laughing out loud, because the one thing on average that didn't get better was the LDL cholesterol, which is what every doctor has been taught, and dietitian and the general public, is to be the only thing you look at. So even I get people who are afraid of this, and I walk them through all of the other things that are improving. And another important point is, don't worry about the cholesterol, whatever parameter you're looking at, until you've achieved your weight loss goal. Because Steve Finney published a paper years ago, and I see it as well, that during the weight loss process, the cholesterol can go up temporarily. and then it will come down when you reach the goal. And these are principles of obesity medicine that other doctors just haven't been taught. Jeff Volek, you've heard his name over and over, started at UConn, now at Ohio State, and this just shows in a different graphical form the comparison between low carb and low fat. And it's not that low fat diets don't work, it's just that high fat diets, low carb diets, a synonym there, work better in terms of triglyceride, HDL going up, weight going down. So the science is solid that this is what happens, even in the context of diabetes. The metabolic syndrome gets better. If you want to wait, if you were one to wait for guidelines, and a lot of people do, the American Diabetes Association put out a paper that endorsed or supported they don't really endorse things, they supported low carb diets. And my colleague, Will Yancey, was the senior author of this paper. He's been on numerous studies of low carb diets. And so there is national recognition at the American Diabetes Association that this is something that you can do for diabetes medically supervised. So in my practice, and what I've been able to figure out or think is true, is I think keto works for virtually everyone when it's done right. And so I see a lot of people not doing it right, and it's often the time, my time is spent simplifying things, but the most important thing is to keep the carbs low. So I've seen people thinking that they can drink keto drinks and be in ketosis and lose weight, fix diabetes. No, not if you're eating a substantial amount of carbohydrates. The most important thing is to keep the carbs low. And we use carb grams per day, not glycemic index, things like that, because it's more precise and it's total carbs. The ketone threshold for most people starts at 50 grams per day. Then I can be sure just about everyone will be in ketosis if they're under 20 grams of carbs per day. Now, you might say, well, why don't you start at 50? Well, you have to understand, my clinic, there's a bit of a waiting time to come see me. I have to have it work right the first time, every time. So you may try other approaches, and if they're not working, come to this approach, the 20 gram or less. I learned it from the doctors who used this over the last century, Dr. Eads, Dr. Atkins. Our role at Duke, Dr. Yancey and I, was that we validated the safety of it. And yes, we've refined things and updated things as well. But the most important thing is to keep the carbs low. That's probably the best message. If you're trying this, it's not working, make sure you're keeping the carbs low. So we did a few analyses of our clinic so far. I mean, we've treated over 5,000 people. It's a medical clinic within a university setting, a private practice that's in the insurance-based system. So over 75% of my patients are within an insurance pay model. Lower number are Medicare, and then just like 5% are Medicaid, or a combination Medicaid, Medicare. So I've learned from my patients how to implement this among a wide variety of socioeconomic levels, what food store you're shopping at, what fast food restaurant you're eating at. I've had to help people figure these details out. And the medical issues, I will basically treat anyone. I'm an internal medicine by specialist training. And I will, as long as we can monitor the condition, and I'm working in conjunction with a specialist who may be in charge, like the heart failure clinic, they will send me people who are too overweight to get a transplant for their heart. They may even have a ventricular assist device implanted. And so I will help manage, we don't use pills, we don't use products, we don't use surgery. This is a low risk as far as medically supervised things go. Of course, with someone who has an LVAD, the left ventricular assist device, you have to be very careful with the vitamin K intake because they're on Coumadin. You have to be careful with the sodium intake because they've had heart failure with sodium overload. So again, this is the medical implantation. I practice the best internal medicine of my life by addressing the food and not using medications. It's really pretty amazing. And I had a student come through a rotation. Yes, you can do a rotation at Duke in the medical management of obesity, and you get rotating experience in many different weight loss approaches, and they come through the low carb clinic or keto clinic. The number of patients seen in this analysis for weight loss was about 2,000 people, and we helped over this 5-year period, 2,000 people lose 26,000 pounds. It's kind of like when someone says, does this work? I'll say, well, does blood pressure medicine work? You see the effect of it. So a doctor in clinic doesn't have to redo all of the blood pressure studies to show that the blood pressure medicine works. They just use it. And so we use this approach and see that it works. Of course, you have to take the pill for the blood pressure, or you have to follow the diet in order to see the results, of course. But this is one reason why I didn't do a large study of my clinic. One is I didn't have the resources to do it, but we see the effects every day. So one method to teach the keto diet, what we use at Duke, we teach people that protein comes first. If you're so appetite suppressed, you need some protein. We don't know how much every day, but you can run your body on carbs or fat. And it's your choice, and you'll run your body on carbs if you eat carbs. You'll run your body on fat if you don't eat carbs. So you have to have that basic understanding at first. So when you're hungry, we can say when you're hungry, eat as much as you want of these foods until you're comfortably full, because for most people, they don't want much, meaning the hunger goes down because they're burning their body fat so well. They can have meat and beef and burgers, of course, no bun. You can have hot dogs and canned meats, and of course, no bread with the hot dog, no bun. You can have poultry, fish and shellfish and eggs. Don't avoid the fat in real foods, but don't add fat if you're trying to lose fat weight. And this is a common misconception that you have to drink ketones or drink fats in order to be keto. No, you don't. If you have extra fat on your body, you will turn that fat into ketones and get the same metabolic effect. So we don't ask people to add in extra things. And you may see a lot now when I teach on YouTube, there are all these ads that come up, and I just say, hey, just ignore that ad. Just ignore that one. I mean, it's usually some product or something that you don't need, when you're trying to do this as simply as possible. So to keep it uncomplicated, we talk about 2 cups or 2 fistfuls of leafy greens. That's for the whole day. 1 fistful or 1 cup of a non-starchy vegetable for the whole day. But I'll say the leafy green or vegetable has to be on this list. So I hand out 1 sheet of paper, again, keeping it simple. It has the list of foods, and I'll say you can't eat anything that's not on this list. So some of my best patients are just people who will follow the rules, and they'll, okay, I did what you said. And one time I had a patient, I planted him in our support group. We've had one every month out in town at a hotel. And I said, why don't you come and just tell people what you're doing? And he got up and said, I've lost 120 pounds in a year. And I said, well, and how'd you do that? He said, well, I just stayed to the list of foods. And I saw the murmur of the other people going, well, maybe we should just stay to the list of. So just stay to the list of foods. It works best that way. So the ABCs of the non-starchy vegetables are, asparagus, broccoli, Brussels sprouts, cauliflower, cucumber, celery. There's something pretty much for everyone on here. And these vegetables fall really low on that glycemic index. So basically a low carb diet follows the same principles as a low glycemic and low carbohydrate diet. They're not like different families. They're like, brother and sister almost, So foods that are allowed in limited quantities, and this is a common mistake I see. People say, oh, it has no carbs. I can have as much as I want. Well, we've learned that it's common for people to eat a lot of cheese, a lot of creams and oils, a lot of mayonnaise. Some people, mayonnaise is a trigger food and they eat the whole jar. Some people do that with peanut butter and all that. So at first, we don't allow people to have nuts or the common trigger foods. So this is a theme that comes through programs that have actually street credibility. They've dealt with people with addiction to food, addiction to carbs, with trigger foods and night eating, all those things. So you limit the cheese, creams and oils, and mayonnaise. These are high calorie items that you can't eat too much and gain weight on a low carb keto diet or not lose weight. olives, avocado. These are things that just make things a little, have some variety. This list I developed based on what Dr. Atkins and Jackie Eberstein, a nurse who worked with Dr. Atkins, they developed in New York City. They were one of the first teams we learned from. We did studies based on this list that they had developed. And then the zero carb snacks will, depend on what you need. If you need something sweet, we don't say, oh, no sweet. No, you can have things that are sweetened with something other than sugar. And then this falls out of the food quality. The food quality police will, I know you can't have, but what do I do with someone who's addicted to sugar? I will use this as a bridge to get them off the sweetness. Again, this is from a clinical setting. Those with diabetes are often the hardest core sugar addicts that I've met, which means they'll crave it, they'll want it, they'll fall off the wagon, you just get them back on. If you need crackers, you need crunchy things, pork rinds have no carbs. These are also known as chicharrones or pork belly, has no carbs, crunchy things. Eggs, I do think, are the perfect food nutritionally. If you think about it, you can make an entire chicken out of an egg. It has everything you need to make an entire organism. So don't fear the eggs. Now, in my practice, I do support people. There's a lot of habit that needs to be changed, and I am part counselor, part cheerleader. I'm part detective to figure out where the carbs were or why something was misunderstood. I mean, this is a big change for a lot of people. It's easy for a lot of people, but it's a big change for a lot of people, and you support, you reduce medication when you can, diabetes and blood pressure medicine being the most common ones that I get to take away from people. In fact, they might have side effects and adverse effects if you don't take away the medication. So if someone feels bad and they're on medicine, suspect the medicine is causing you to feel bad, not that the diet's making you feel bad. So no shame, no guilt, no embarrassment, stick to the basics. And our list of food is called Page 4. It just got out there as a meme on the internet, and it's just one sheet of paper. It's actually the fourth page of our handout at Duke. So I see a lot of I coach and counsel and remind people that 1 to 2 pounds per week of weight loss is fantastic, especially if you have diabetes. Many of these people have not lost weight in years, and this helps you fix diabetes and the weight at the same time. Do a lot of, again, support, scan the family, the workplace for the naysayers and the carb pushers and the saboteurs, if you will. I screen for medicines in the springtime in our area. The nasal spray with steroids come out, doctors prescribe them, and then I take them away and push the other types of antihistamines because that can actually make you gain weight. Of course, insulin is the most powerful medicine to help you gain weight with the steroid pills like prednisone, and we work hard to get people off these medicines. So let me shift to some practical reality about the diabetes treatment. This is Janet. Janet says on the bottom left, after 10 years taking diabetes medicines, my doctor prescribed insulin. I searched for a better answer because I didn't want to have diabetes in the first place. I mean, nobody wants to have diabetes, right? The disease went away with a low-carb diet and no more medicine. So she lost 130 pounds. Her A1C went from 8.4 to 5.7. She's no longer diabetic. Like the Virta Health study, Hallberg study, you can put diabetes into remission using dietary approaches, including nutritional ketosis or a low-carb keto diet. And this is what keeps a low-carb keto doctor going to work every day. We see results. And then again, in my clinic, I have people from all walks of life. This young man decided to only eat at a fast food establishment that has a $1 menu. And so he came back losing weight at a 10 to 15 pound month clip, just eating off the $1 menu, 2 or 3 double cheeseburgers, no bun, no fries. He was only hungry once a day. And then you can see the weight coming down from 360, 370 to 300-ish. And then spring break, in our area, they go down to Florida. The kids go down to Florida for spring break. He didn't gain weight, but he was happy that he didn't gain weight. They didn't lose weight, but he didn't gain weight either. So this was just obesity. I wanted to just bring in the dirty keto idea as an approach that you don't have to worry too much about the food quality, and it will still work. Now, there's a keto medicine principle, which is you don't treat insulin resistance with more insulin. And insulin resistance is the precursor to diabetes. Now, so it makes sense for type 1 diabetes. This is if you have no insulin at all. And I saw on the question earlier, can you fix type 1 diabetes? No, you can't, but you can have people take less insulin, which means fewer low blood sugars, means better glycemic control. But when you come to type 2 diabetes, you might be surprised that the insulin is already high when you have type 2 diabetes. Just ask your doctor to check it. This has been referenced in this series at the summit with the Kraft test, the carbohydrate glucose tolerance test. So you don't give more insulin when the insulin's already high. What you want to do is reduce the glucose going into the body to target the insulin resistance. And that's what a low carb keto diet does. So if someone is on insulin, that's going to pretty much guarantee you're going to gain weight. And if weight is the cause of diabetes, that means you'll never fix the diabetes unless you get off the insulin. So you want to work with someone who can help you get off the insulin. Now, let me show you some examples of this. It's replicable. It's expected. But how fast it happens can differ. So what I do in this figure, I add up all of the insulin, whether it's long-acting, short-acting. This person was on 80 units of insulin per day. The low-carb keto instruction in the middle of the graph, insulin is reduced by 50% on the first day to avoid hypoglycemia or low blood sugar. So you don't want to do this if you don't know what your insulin and glucose is doing, what it does. You want to monitor, work with a health practitioner who can help you understand this. But if the glucose is under 100 milligrams per deciliter, then you don't want to take any insulin at that time. And what I'll do is say, what would happen if you took insulin if the blood sugar was 100? And if someone doesn't know what insulin does, I work really hard to educate, keep things even simpler. Some people are on insulin and they don't know what it does. So you want to make sure someone understands that. I think you're going to hear some other approaches that use continuous glucose monitors, which is fabulous. I'm not doing that yet. I'm just having people check their own blood sugars. So here in 1 week, this person was off 80 units of insulin because they stopped eating carbohydrates and the blood sugars were better than before. So I'll always look, were the blood sugars better, as good, or better than before? Don't think that they're going to be normalized automatically initially, but they need to be better than before. So this next patient was on 60 units a day, was reduced down to 30 units in the first day, and then was off by 2 weeks without eating carbohydrates, just by checking the blood glucose, and it was under 100. They stopped the insulin on their own with that instructions. And then you can look down at the bottom now, we're measuring the insulin went from 60-30-0, the weight went from 306 to 300, so you're losing weight as well, which is great. That's the underlying cause of insulin resistance. For most people, you want to lose weight and cut the carbs at the same time, which a low-carb keto diet does. So this patient was on 100 units of insulin. Blood sugars were not well controlled. They were up to 250 and had low blood sugars down to 50, and the insulin 15 3 times a day, just showing you what that means, and then 60 units long-acting in the evening. And in 3 weeks, this person lost 17 pounds and was off 100 units of insulin with these instructions and monitoring the blood sugar finger sticks at home. It's pretty amazing. In fact, it's so unbelievable, people don't believe it. So another patient came in and said, I had insulin. I've been on insulin for 10 years. I know I'm going to have diabetes forever. I politely explained, well, maybe not. Let's do this one step at a time. This person was on 170 units of insulin, had been on insulin for 10 years, and was off insulin in a week. So basically, the insulin was treating the food. Remember, you're taking away the food contribution to the blood sugar elevation. And so in this 6-week period here, the blood sugars were almost normal, off of 170 units of insulin. And oh, by the way, they lost 21 pounds as well. Now, I remember being criticized that this was too much. How do you don't know that if it was the food or the weight loss that improved? I don't care. It's both. I mean, so it's a multidisciplinary or multifactorial kind of approach. Just showing quickly now industrial levels of insulin, 160 units off in 5 weeks, almost 300 units off in 4 weeks. Now, the insulin approach to type 2 diabetes has led to more concentrated insulins. So you'll see people on U500, which means it's the 500 units now are crammed into 1 milliliter. And that's okay. Just with the same process, same monitoring, taking people off. And there's no one who is happier than to get off the diabetes medicine and then to stop monitoring for the blood sugars. So as the Veer to Health study shows in the medical literature, what we low carb doctors see clinically is you can fix or put diabetes into remission, reverse it, and cure it. The definition is if the diabetes is gone for 5 years, you've achieved a cure, and that is achievable. Just wanted to give a clinical alert. These new drugs have been tested for heart failure and heart. Doctors like to give these medications called SGLT2 inhibitors. I've never seen ketoacidosis in my clinical practice until these medicines were used. And there's several case studies being studied already and published. So my recommendation is to stop one of these SGLT2 inhibitors when you're starting a keto diet. So I hope I have simplified a few things. This fire hose of information coming at you. I'm focusing on the low carb, high fat diet, LCKD in the clinical setting, known as carb restriction in the medical literature. And to just wrap up, keto is safe and effective for obesity and type 2 diabetes. Keto works for virtually everyone when it's done right. Keeping carbs low is the most important thing. As with any lifestyle change, behavioral support may be needed. I think sometimes I'm teaching someone how to ride a bike, and they might fall off at first. You just get back on. It may take a few attempts, but eventually just about everyone can ride a bike or do a keto diet. If medical conditions are present, then please listen. Monitoring to safely de-prescribe the medicine is needed. Unless you're a doctor or a nurse to understand what you're doing. Just wanted to point out again the Adapt Your Life Academy. If this is interesting, stay tuned because at adaptyourlife.com, and Adapt Your Life Academy will be teaching you how to do this simply from a distance. Also delving into the treatment of medical conditions that at first we're targeting the non-medical audience, because as you can see, monitoring from some of these people can be pretty intensive. And then End Your Carb Confusion coming out in December. Be sure to pre-order if you're interested, now available at amazon.com. Thank you so much for your attention. It's great to be involved in the NSNG Summit.
All right, Dr. Westman, thank you. If you can close out your screen sharing, then we just have a couple minutes for some questions. So if you want to pop up that little thing on the bottom that says ask a question, you can see the questions that people have asked.
Okay. Yeah, so number one question. I was wondering, rebooted here. How many days a week of 20 grams or less does it take for a person to become ketogenic? Well, the traditional teaching is 1 or 2 or 3 days. So most people after 3 days. Well, we've done some studies now where now people are measuring their blood glucose, which is even more precise than urine and breath. Some people are knocked out of ketosis for 2 weeks. So and don't despair about that. Just realize that it's someone who has had an obesity, diabetes problem since childhood, and they have extreme insulin resistance. And so we've seen some people who take 2 weeks to get back into ketosis, although for most people it's 3 days or 2 days, or you'll know the hunger's gone. Most people don't detect a taste in the mouth or urine, some do, but the absence of hunger is probably the hallmark of ketosis. The next question, what's your opinion of artificial sweeteners? Well, I need them to get people off sugar for the true sugar addicts. So do I think that they're necessary or helpful? No, I don't know of any study that says you'll live longer, but if you enjoy those things, I'm more of a, how can I help people do this for the long haul? And I think artificial sweeteners are okay. Not for everyone, so for example, if you get an aspartame-related headache, I would say don't have aspartame. But you'll see that my approach is to try to expand, get the most people to be able to do it. And if one person can't do it, I don't say everyone can't do it. It's that my experience is the clinical setting of lots of different people. Next question, what do you suggest for my 10-year-old daughter doing NSNG? Is it okay for a growing kid? Of course. This is just healthy food. It's just healthy eating. And remember, the whole idea that having carbs and worry of fat and all that was a mistake. There was a misdirection. And I think this is healthy for anyone. It turns out that babies are born in ketosis. And so I know that it's not a very scientific statement, but it might relieve your concern about it. You'd mentioned fasting previously. What are your thoughts on fasting? Well, again, show me a paper, 50 people over 6 months in a peer-reviewed journal with all the metabolic outcomes that you would expect, and I'll comment on it. It really hasn't been addressed at the scientific level. And I know, you can watch the show Naked and Afraid on TV and see the total fasting leads to losing a pound of weight per day for these people. But what we want is the healthiest way to help you lose weight. Now, if you're monitoring your body composition, doing it with someone or under the guidance of someone who's been doing it a long time, I have no problem with it. If you are eating carbs and you're fasting, you may have really bad hunger, and I don't think you should power through hunger. I think you should be eating when you're hungry. So if fasting happens as a consequence of a low-carb keto diet, I think it's great. And if you want to think of it as intermittent fasting, I'm doing OMAD, 1 meal a day, then great. But you have to be eating the protein first. So I know we really need more research in that area for the kind of research crowd. I mean, I never thought that I'd be the mainstream, consensus, status quo or the dogma, but the dogma tells us that you should have some protein every day.
All right, unfortunately, that's all the time that we have. Thank you so much, Dr. Westman. That was an incredible presentation, and thank you, everybody, for joining us for it. We will be back in 7 minutes with Dr. Sean Baker, and stick around. Thanks again, Dr. Westman.
Thanks, Andy. Appreciate it.
All right.
Thank you.